Thanks, Steve, and thanks everyone for coming out on this cold and rather wet night. So I'm going to cover this evening the early days of AIDS, the early treatment. It wasn't great. Then we got better treatment, but we got complications. I'm going to cover great treatment and ageing with HIV. And then I'm going to talk a little bit about whether we will be able to see the end of HIV and AIDS in the near future. So if we just set the scene, over the last 30 years there's been 71 million people infected with HIV. 35 million people are currently living with HIV. And in 2012 alone, 2.3 million people were newly diagnosed with HIV infection, and 1.6 million people died of AIDS in 2012. And if we contrast that with, we've cured one person with HIV, a Berlin patient. He had 2 bone marrow transplants, and we're not entirely sure what led to the cure. And there is perhaps a functional cure in the Mississippi baby, and we're going to hear more about these cures at the AIDS conference coming up. It was also just over 30 years ago that I was selecting a choice of specialty, and I chose infectious diseases. I was interested in infections, but I also chose infectious diseases because people got better and there was very little chronic disease. And that all changed in my last year of training. My last year of training was 1984, and that was the year that AIDS arrived at Fairfield Hospital. It was young men in the prime of their life with awful infections and malignancies. And they chose to have their care delivered at Fairfield Hospital, where there was gardens, tranquility, and a sense of peace. And there was also open space and lots of peacocks. The AIDS ward is the middle floor here of the central ward block. So the first case of AIDS was actually in 1983 in Victoria. It was a sort of a retrospective diagnosis, and the first cases of AIDS appeared at Fairfield towards the end of 1984. The Medical Journal of Australia described AIDS as the Black Plague of the 80s, and they were incredibly criticised for their choice of image for the front page of the journal. The federal government chose the Grim Reaper campaign, which was also not without its critics, to raise awareness of HIV and AIDS. And it probably did result in prevention of infection, but it also was the beginning of stigma and discrimination for the affected communities and also the patients with HIV and AIDS. Fear and ignorance were also part of HIV and AIDS in those early days. In the community, there was major overreaction. Patients had to deal with fear and ignorance in healthcare workers. And the media also had a role with overreaction and hyperbole with some of their headlines. So what is this virus that causes this infection? Human immunodeficiency virus, HIV, infects cells of the immune system. It infects CD4 T lymphocytes. Now, it's really a very clever virus. It infects the cells that are there to kill invaders. And CD4 cells are also important because they are the conductors of the immune orchestra. They tell the immune system they need to turn on because there are foreign invaders, viruses, bacteria or fungi. And they have another important role in telling the immune system it can stop now because that foreign invader has been dealt with. But what happens with these CD4 cells, they become factories of HIV replication, and the HIV viruses are released from the cells die, and they're free to go and infect other cells that have the CD4 receptor on their surface. And what happens is there's this constant destruction of CD4 cells, and it gets faster and faster, and the lymph nodes are unable to keep pace. And so you end up getting lower and lower numbers of CD4 cells, and you have immunodeficiency. And what happens when you are immunodeficient is that viruses and bacteria and fungi that don't normally cause disease in humans take the opportunity of that defective immune system to cause disease. And that's called opportunistic infections. And opportunistic infections is what we were seeing in our patients. This is Kaposi sarcoma, and this was one of many of the feared complications of HIV infection. Kaposi sarcoma had this predilection of occurring on the face, these purple lesions that were obviously Kaposi sarcoma lesions. And it was like putting up a sign to say, "Hello, I've got AIDS," with these lesions on the face. And patients would try to cover them with any means that they could. Other infections that were feared were the pneumocystis pneumonia, the brain abscesses from toxoplasmosis, and finally, cytomegalovirus retinitis. This is a normal retina, which is the back of the eye, and it includes all of the nerves that you need to see. And this is an eye that has an infection with cytomegalovirus, and you can see all of the hemorrhages and the exudates. And what happens is that retina dies, and you lose vision in that area. And this was the feared complication, to go blind from CMV retinitis, and many of our patients did go blind. So what were those days like? They were tough. They were really tough. They were tough for the patients. They were tough for their partners. They were tough for the carers. They were tough for the friends who were wondering, am I going to be next? But they were also tough for the doctors and the nurses, who were incredibly frustrated by their inability to alter the outcome for these individuals. 50% of our patients died within 12 months of a diagnosis of AIDS. I would see some of my patients more often than I would see friends and some of my family. And when a patient died, I felt like I had failed them. And when we were seeing so many deaths, that were escalated to this constant sense of failure. So in those days, I came back from the United States and I set up the clinical research unit at Fairfield Hospital. In fact, I was the clinical research unit at Fairfield Hospital. And we started and focused on treatments of opportunistic infections and trying to prevent opportunistic infections. And we became so busy that I was soon joined by some excellent research nurses, some of whom have been with me ever since. We needed to manage and better manage opportunistic infections, and we needed to prevent them. In the late 80s, Suzanne Crowe came back from the United States, and she set up the first capability of measuring the CD4 cells, or the T cells, that were affected by HIV, and which are a measure of the immune damage caused by the virus. And patients would come to the clinic and their first question would be, what is my T cell count? And in those days we couldn't really do a lot with the T cell count, but we knew what levels were dangerous for patients. We also had our first antiviral, AZT. AZT blocks the multiplication of the virus, but as we were soon to learn, it only does it for a short period of time. And in fact, it developed quite a bad name. It was called AZT poison. AZT kills patients, as you can see from this demonstration at a conference. And this was because of the very clever virus that was able to overcome the AZT by developing resistance to it. AZT was also a nasty drug. It had lots of side effects. Patients had headaches, they got anemic, and they felt tired. It was a shocking drug, and in those days it needed to be taken every 4 hours. So patients were setting alarm clocks at 2 a.m. to take their 2 a.m. dose of AZT. It was at about this time that we were able to measure the HIV viral load, and again it was Suzanne Crowe who set this testing up in the Burnett Institute. And we started doing clinical trials of AZT and some of the related drugs that were really pretty ineffective. But we needed to do these studies. They needed to be placebo-controlled studies. And what that means is that half the patients got the actual drug and half the patients got the placebo. We needed to do that to see if there was any effect of the drug and whether it caused excessive harm or not. But patients were so altruistic, they would line up and be recruited into these clinical trials knowing they only had a 50% chance of getting that drug. So the clinical research unit continued doing trials. We had new drugs coming along. We tested 2 drugs versus 2 drugs and 2 drugs versus 3 drugs and this regimen with this drug and that regimen with a different drug, trying to find the best regimen. And then 1996 came along, and it was the year that everything changed. It was the International AIDS Conference in Vancouver, the same conference that is about to happen in Melbourne in 1996. And David Ho, who was later named Time Man of the Year, presented the results of studies with this new class of drugs, protease inhibitors. And it was a 3-drug regimen. And he boldly got up and said, "We can cure HIV in 3 years." That was 1996. My first slide showed you we have cured 1 person since over 30 years. So the scientists learnt that the virus is a very clever virus, and it infects cells that are very slowly turning over, and it inserts a copy of itself into the DNA of these very slowly replicating cells, and it hibernates. So that the mathematicians did some modelling and established that patients would need to take continuous antiretroviral therapy for 68 years to be cured of HIV. A tall order. In 1999, David Ho modified his "we're going to cure HIV in 3 years" to "we're going to change HIV into a chronic manageable disease like diabetes." And again, they were famous last words. So the new treatments really had an enormous impact almost immediately. As you can see from this graph, this is a graph of deaths, annual deaths, from the combined databases of the Alfred and Fairfield Hospital. And you can see reductions in the death rate. We also saw massive reductions in hospitalisation and progression to AIDS, reductions in opportunistic infections. The new combination treatment worked and everyone was excited. In fact, this is the August the 13th, 1996 edition of the San Francisco Bay Area Reporter. They reported that for the first time in 15 years, there were no obituaries for people with AIDS. And they celebrated that by putting that on the front page of their newspaper. 1996 was also a sad year for many people. There were after many years of uncertainty and struggles to survive, the Victorian government decided to close Fairfield Hospital. It was really an anomaly as an infectious diseases hospital in the world. So Fairfield Hospital closed and the HIV service moved to the Alfred. And initially it was tough. The clinicians were finding new ways they had to do things, and we were struggling. We wanted to maintain that Fairfield culture of care. But when I look back to those days, and I realised that that was the best decision for our patients, because HIV disease was changing. And we needed access to new diagnostics, new imaging techniques, specialists, and the days of transporting patients for an MRI scan in another hospital were really unsustainable. So it was a sad year, but it was great for the patients. So the euphoria over the new patients lasted a short time. In 1997 or 8, lipodystrophy syndrome was described first off by Andrew Carr and David Cooper in Sydney. What they were doing was that they were sending their patients off to the vascular surgeons to fix their varicose veins, and the vascular surgeons were sending the patients back to the HIV physicians saying they don't have varicose veins, they've just got no fat to support their veins. And so this is what you would see, very prominent veins in arms and legs and very scooped out appearance of the face due to loss of fat in the subcutaneous tissue. This again was like putting up a sign and saying, I have HIV and I'm on treatment. And so what happened is, with the inadvertent disclosure of HIV, there was widespread reluctance to start treatment, and there were a lot of people stopping treatment, hoping these body shape changes would go away. The other thing that was happening was that the fat was being deposited in the visceral fat area around the gut, and with increasing girth, you get an increased risk of diabetes and also cardiovascular disease. And that's exactly what was happening with one of our earlier protease inhibitors. We were diagnosing diabetes, chronic manageable disease like diabetes. Yes, we had HIV and we had diabetes. So my research focus then shifted towards what is happening with these new drugs. Why are they causing this lipodystrophy syndrome? How can we prevent it? How can we reverse it using different strategies? The focus of treatment then became undetectable viral load. Patients would come into the clinic and instead of asking what their T-cell count was, they wanted to know, is my viral load undetectable? What is it? Now, undetectable means different things to different people, and we had to make sure that people didn't think that undetectable meant that they were cured of HIV. And in fact, undetectable just means that the result of the test, the viral load measure, is below the detection limit of the test being used. Our first tests in 1996 only measured down to 10,000 copies per mil. Today we would consider that shocking virological failure. Today we use a test that measures down to less than 20 copies per mil. This is quite a different level of virus. So the evolution of HIV care in the pre-antiretroviral treatment era focused on management of opportunistic infections. We wanted a drug that might actually keep people alive. We wanted to reduce mortality. In this middle era of antiretroviral therapy, the focus moved to this lipodystrophy and body shape changes that we were concerned about. Because the drugs weren't particularly effective in that patients were developing virological failure, we were seeing a lot of resistance and we needed to manage that. We wanted to find drugs that had less toxicity and we wanted to increase life expectancy. In the mid-2000s, a few new drugs became available, and one of them was this drug called T20. T20 is an injectable, and you had to inject this drug twice a day into the subcutaneous tissue of the abdomen, as you can see in that picture. But what happened when you injected that drug was that there was a reaction to the T20, an injection reaction, and patients would experience a hard, tender, red area, nodular area on their abdomen. And because it took 72 hours for that reaction to go down, at any one time, patients would have 8 of these over their abdomens. And over time, this tissue became really hard and it was hard to inject into it, and patients would bleed. But T20 was remarkable. The clinical research unit would have patients coming in tears because for the first time in 15 years they had an undetectable viral load. And that T20 was able to keep patients alive until better tolerated and better drugs came came along. In another attempt to reduce toxicity, an international study called the SMART study commenced in 2002. The aim was to see whether we could reduce the toxicity from the available antiretroviral drugs by using it when you needed it. And that is when you got close to that CD4 cell level where you're at risk of opportunistic infections. And then to stop the treatment when you had high CD4 cells and you weren't at risk. So patients would go on and off their antiretroviral treatment. And that was compared with continuous treatment, which was thought to cause a lot of disease that caused the lipodystrophy syndrome, it caused lipid abnormalities, it was thought to cause cardiovascular disease, kidney disease and liver disease. So the SMART study started, and I was the principal investigator for Australia for the SMART study. We recruited somewhere around 5,500 patients when, on my summer holiday in January of 2006, I was on the beach, it's the Portsea Back Beach, and my mobile phone rang. And I was told that the Data Safety Monitoring Board had recommended that the SMART study close immediately. No further patients were to be recruited, and all patients on that intermittent therapy arm should go on treatment. Why was that? It was because those on that intermittent treatment arm had double the death rate, had double the rate of progression to AIDS, had more cardiovascular disease, liver disease and kidney disease, which we didn't expect. There was an editorial about this study. This study was very hard to get off the ground because people believed they already knew the answers. It was safe to have treatment breaks. You didn't need to worry about all of this toxicity. And this editorial told us that clinical endpoint studies are still really important. The SMART study also caused a paradigm shift and a new research agenda. It's been amazing, the change in research since the results of this study. Because of the unexpected finding of increased cardiovascular disease, liver disease, kidney disease in the intermittent treatment arm, we now are focusing on the causes of that, and chronic immune activation and inflammation as one of the contributors has been investigated in many laboratories around the world. Bone disease, however, was the only organ system that got worse with continuous therapy. And so we need to understand why that is so as well, because osteoporosis, just like atherosclerosis, is an inflammatory disease. But clearly the drugs that we're using cause more bone loss than the immune function. The other thing that was important with this study was the foresight that the investigators had to collect and store an enormous sample repository which has been used by hundreds of people around the world to try to understand the results of this study. A number of epidemiological studies have occurred also following this study. And there have been studies of anti-inflammatory drugs and statins also trying to improve the outcomes for patients. The other study that was really important, that was the son of SMART, is the START study, which is looking at when is the best time to start treatment for an individual, not a community, an individual. As far as toxicities, what is the risk and benefit relationship between the toxicities of medication and the benefits of treatment, which are clearly immense, as the SMART study showed us. So are people with HIV at increased risk for chronic age-associated disease? We can now look at some better epidemiological studies with the right control group. This is a study from the Dutch. And it looked at a group of HIV-positive individuals at different ages and compared them from the same clinic with HIV-negative individuals. And if you just focus on those that are over 65, you can see for the HIV negative group, about 45% have 2 or more comorbidities. But if you look at the HIV positive group, it's 75% have 2 or more comorbidities. So yes, we do see more comorbidities. There is also, there's been a lot of questions about accelerated ageing, premature ageing, and I don't think that we really have premature and accelerated ageing. It would only be a few years difference. What we're seeing is an increased rate of age-associated diseases in our patients. But do our patients have a normal life expectancy? This is data from Denmark, and it looks at the 3 different eras that we've been talking about this evening: the pre-treatment era, the middle era of not so efficient treatment, and the era with good treatment. And you can see on this graph, this is the pre-treatment era, this is a diagnosis at the age of 25, and 50% of people died within 7 years of a diagnosis at 25 without treatment. If you look at the middle era, it's 24 years from diagnosis, and with good antiretroviral therapy, it's 38 years. But we still have the general population sitting up here. So we know that life expectancy isn't fully restored for people living with HIV. Why is that? It's because HIV, with its infection of those CD4 cells, causes multiple immunological abnormalities, including immune activation, and immune activation leads to chronic inflammation, and chronic inflammation leads to many of the conditions that we're talking about as comorbidities. So if we look at some of the comorbidities that are increased in HIV, and some of the drivers of those, it's still antiretroviral toxicity, but there's also lifestyle factors, and they all contribute to ageing. Now, my research has changed focus again off the lipodystrophy and onto some of these non-communicable diseases, in particular cardiovascular disease and also bone disorders. So, I have this marvellous PhD student who is helping me look at cardiovascular disease, and we're looking at the contributions of HIV, of antiretroviral therapy, and of the traditional risk factors of cardiovascular disease. Now, if I just show this one graph of people who are veterans, the Veterans Affairs have this amazing database, and they can look at rates of AMI, is acute myocardial infarction or heart attack, per 1,000 person years of follow-up in different age groups. The red is HIV positive, the orange is HIV negative. So there's not a lot of difference at 40 to 49 years, but at 50 years there's almost double the rate of heart attacks, and the same at 60 to 69 years. So what are the drivers of this increased risk and event rate? The drivers are HIV and antiretroviral therapy and their effect on lipids. HIV needs cholesterol to multiply. People with advanced, untreated HIV have actually low cholesterol levels. You start antiretroviral therapy, you have this return to health, but you also get a marked increase in cholesterol levels as an effect of some of the drugs. We've talked about the HIV immune activation and inflammation, and we know that that occurs, and this is an artery which with inflammation has started, and then lipids start being deposited in that inflammatory area. And I think you can see that with time and this increase in this inflammatory condition, there is decreasing lumen of the artery, and then the platelets, the cells that form clots, finally block off that artery. There's no oxygen that can go, and the muscle that's beyond that artery, it's heart muscle, dies. It's a myocardial infarct. So that is the way the immune activation and inflammation drives it. We also know that our patients have an increased rate of risk factors, which I'll show you in a moment. And there is one particular antiretroviral drug that may affect the platelets and cause platelet hyperreactivity to cause those clots. Genetics. We can't get rid of genetics. We have to live with our family history of heart disease. We can't change that. And that also has an important role to play. So the first thing that Janine did was to look at a cohort from the Alfred of patients who had coronary artery disease. So 3.8% had coronary artery disease. And our rate, our incidence of cases was 8.5 cases per 1,000 person years. And if you think back to the graph I showed you earlier, this is greater than what was seen at the Veteran Affairs. But 50% of our patients are smokers. It's not true anymore. In 2014, 30% of our patients are smokers. We have actually encouraged a lot of people to stop smoking, but there was a publication that was released yesterday that says that 15% of the general population are now smokers. So we still double the rate of the general population. 40% had hypertension. That came as a surprise to me. I hadn't thought so many people would be hypertensive. And 55% had a history of cardiovascular disease. So what changes are associated with HIV? What changes are associated with antiretrovirals? And this is the focus of a lot of research that my PhD student and I are doing in collaboration with a number of partners around the AMREP campus. The first thing is there's good cholesterol and bad cholesterol. The good cholesterol is LDL cholesterol, and it increases your risk of a heart attack. The good cholesterol is HDL, and it has a preventative effect on heart disease. So patients with HIV tend to have a low HDL. Why is that? And that's because the virus actually blocks HDL. And in fact, the virus blocks reverse cholesterol transport, as we've shown with collaborators in the Baker, causing accumulation of fat in cells. Just dividing cholesterol into total cholesterol, LDL, bad cholesterol, HDL, good cholesterol, and triglycerides is a simplification. In fact, there's about 20 lipid classes and over 400 lipid species, and they can be measured using this special machine called a mass spectrometer. Can't say it. A very good machine that they have in the Baker. Now, what Janine has been doing is she has been using samples from a number of studies, including our case control study of heart attacks, but also of studies of patients initiating treatment with different classes of drug to see how the lipid species change with treatment and whether they become more like the patterns seen in individuals in the community who have had a heart attack. So that's one line of research. Another line of research with collaborators in the Australian Centre for Blood Diseases has been to look at this drug abacavir and how it might be causing this increased rate of myocardial infarcts or heart attacks. And it's only current use of abacavir that appears to increase the risk. So the biological mechanism is uncertain, but we're punting that it's got to do with the platelets. And so Janine is investigating that in patients who are stable on treatment and have abacavir added for a couple of weeks. And finally, because we know that cardiovascular disease is more common in HIV patients. We're doing a study of rosuvastatin in patients with an intermediate risk of HIV, wondering whether the inflammatory condition set up by HIV might respond well to statins at an earlier stage than one would start a statin in the general community, according to the guidelines from the Heart Foundation. We're measuring progression of disease by measuring atherosclerosis, and this can be done using an ultrasound probe, which is placed over the artery in the neck. This is the carotid artery. And this is the resulting measurement that we get. And what we're measuring is this thickness here. This is called the carotid intermediate thickness and is a measure of atherosclerosis. So this is what the outcome measure for that study will be, because we're not recruiting enough patients to measure actual clinical events. What about bone disease? Osteoporosis is a silent disease. It's silent until you get that fracture. Osteoporosis involves thinning of the bone. The trabeculae are thinned and there's low bone mineral density. And then what happens is the hip is one of the more common areas where you fracture with a minimal fall, or you fracture the vertebra in the spine, you lose height, and your spine becomes convex. So not a nice disease. We know that patients with HIV have more low bone mineral density than others. We know that osteoporosis is more common in HIV, and we know fragility fractures are more common in HIV. Is it the virus? Is it that inflammation set up? Osteoporosis is now being considered an inflammatory disease, so it's possibly the virus. Is it the increased prevalence of predisposing lifestyle factors like smoking, alcohol, glucocorticoids, or choice of recreational activity leading to an increased risk of fall? Or is it antiretroviral therapy? We know from many studies that when patients start antiretroviral therapy, they lose up to 5% of their bone mass in the first year of treatment. And that loss is greatest with particular drugs used in the antiretroviral regimens. So what is the link between HIV and bone disease, and what is the pathogenesis of the bone loss with antiretroviral therapy? And I'm leading a sub-study of that Son of START, looking at bone disease in patients in this study. So there have been 4,600 patients recruited to START, and 400 of them agreed to be in the bone mineral density sub-study. What we're doing is we're measuring bone mineral density using a DEXA scan. And this is the results that come out of a DEXA scan. We measure it at the hip and at the spine. And the measurement is compared with someone the same age and the same gender. And then the point is placed where you fit according to the general population. We're going to measure bone loss before people start on the study, and then while they're off treatment for those that are off treatment, and as people start treatment for those randomised to start treatment immediately. We're going to measure risk factors for bone loss, and we're also collecting lots of specimens to look at the crosstalk between the immune system and bone disease. With Andrew Carr in Sydney, I'm also looking at how we should be managing osteoporosis in our patients. We know the drug that is the most common cause of bone loss. We've already done a pilot study which shows that if you switch off that particular drug and start others, you can gain bone. But we don't know whether that's a better strategy than just treating with a bone strengthening medication such as bisphosphonates. The other thing is we don't know whether we should be screening or not screening our patients, what age should we start screening, which measures should we use, how frequently we should do it. These are other areas of endeavour for me. So it's 2014 and we've got 20 new drugs since 1996. And one of the most important new formulations is this fixed drug combination. So in one pill there are 3 drugs. And this has made an enormous difference to patients initiating treatment on antiretroviral therapy. And you can see that we have 3 of these fixed dose combinations available to us. The difference between 1996 and 2008, this is actually a tripler. And it's really revolutionised the ability of patients to adhere to treatment, which is very difficult when you're taking that number of pills a day. So today, virological failure is uncommon, and people taking treatment breaks is uncommon. And so in our evolution of HIV care, we're focusing on non-AIDS events in the clinic. We're looking at longer-term tolerability of our drugs because it's still treatment for life. And we're looking at ageing with HIV. So I go to the clinic now, and in about 30 seconds we deal with HIV, the viral load is undetectable, CD4 cell counts in the normal range. And then we deal with the changing clinical spectrum of HIV. We deal with all of these things. There's increased risk of cancer, vitamin D deficiency, much more diabetes. I've had to learn to take blood pressures again. Looking at lipids, looking at body shape changes, cardiovascular disease, looking at risk algorithms. But we're developing a new kind of pill burden for our patients. We managed to get down to 1 drug for their HIV, but we need the statin for their lipids, the fish oil to get their triglycerides down, treat their diabetes, treat their blood pressure. In Victoria, if you look at 214, almost 50% of our patients are over the age of 50. 50, I'm told, is old. I think it's relative, really, but 50 is old in HIV. Here at the Alfred, we also have 50% of patients, 49%, who are over the age of 50. Is there a difference for those that started treatment before 1996 compared to those that started treatment recently with the better tolerated drugs, 1 pill once a day? I think that's something that we'll be looking at. There's a legacy of starting treatment with AZT and some of those older drugs. There's mitochondrial toxicity, there's adverse effects, there's increased cardiovascular disease, increased diabetes, increased fat changes. Really makes a big difference. So our patients who are ageing with HIV are likely to have an increase in these complications. And 1/3 of our patients are in that situation, while 2/3 are aged with HIV. And they'll have a different trajectory of disease compared to the ones that have been around for a lot longer. So I became an infectious diseases physician to manage infectious diseases, and in the late 90s I became a virologist and I managed virological failure. Today I have to be an internist and manage blood pressure, hyperlipidemia. I trained as an infectious diseases physician. I didn't really train in internal medicine, so we've had to develop guidelines for our infectious diseases physicians that manage all of these HIV patients on how to screen and manage simple management of a number of comorbidities that our patients have. But overall, I think we should be celebrating ageing with HIV. It's fantastic that everybody is ageing with HIV. Another thing that has changed is that in the late 80s, early 90s, women were not encouraged to become pregnant. And now pregnancy is celebrated as well. We've started a women's and children's program here at the Alfred in 2009 that has obstetricians, paediatricians, infectious diseases, physicians and nurses coordinating the care of pregnant women. And in that time, 70 women have had 83 babies. And absolutely every one of those babies is HIV negative. We've also developed a program for couples that are discordant, where one partner's positive, the other partner's negative, and they want to have a baby. We want to make it safe. We don't want the partner to become infected in the process of conceiving. So we have this program where we wash sperm, and the washed sperm that is free of HIV is then either inseminated intrauterine, or we use IVF for people with some fertility issues. And again, the program has had remarkable success in achieving pregnancy for a number of our women. And we're about to start a new program where we're going to give pre-exposure prophylaxis to the HIV negative partner to try to prevent HIV infection. 2011 came, and treatment as prevention was the breakthrough of the year. This is where treatment of HIV positive individuals, getting that viral load down to undetectable levels, virtually eliminates transmission of HIV to others. And this is really very important on a global scale. But this graph shows the cascade of care. This is from a few years ago in the US, where they projected 1,200,000 patients were likely to be infected with HIV, but only 80% of them actually were diagnosed with HIV. And of those diagnosed with HIV, only 77% had been linked to care. And of those linked to care, only 66% remained in care. And of those, nearly 90% were on treatment, and nearly 80% had a suppressed viral load, which is what we hope we're doing successfully in our clinics. But we need this suppressed viral load to be up here at the same number of those with HIV infection for treatment as prevention to be effective. So we have a lot of work to do to go out and find our patients with HIV. So what are the challenges ahead? The challenges ahead are 0 new infections, 0 AIDS-related deaths, and 0 discrimination. And unfortunately, for the majority of our patients, discrimination and stigma is still rife. And it's time we said enough. No more stigma and discrimination. And we need to allow our patients to become resilient. What will it take to end AIDS? It will take seeking, testing and treating, finding all those that are HIV positive and treating them to eliminate the possibility of transmission. We need treatment as prevention, particularly for our discordant couples, but also for the community. And Edwina Wright has just started a pre-exposure prophylaxis demonstration project in Victoria to demonstrate that individuals at very high risk of HIV infection, we can prevent that infection by giving them some antiretrovirals. The cure. We still need the cure. Treatments for life. Diagnosed at 25, you're going to be taking pills for 50 years. Why do we need a cure? We need a cure because life expectancy remains reduced. There are ongoing side effects and diseases, and really the funding for 35 million people to take antiretrovirals for life is unsustainable. So we have this great conference coming up. I'm going to be here in 10 more sleeps. And there are going to be researchers from all over the world coming to share new treatments, new ways of managing HIV. The social dimensions of HIV will be discussed, how we can eliminate stigma and discrimination as well as HIV itself. So this is a really exciting time for Melbourne. It's fantastic. So in finishing, I'd just like to thank and acknowledge all of the people that I work with, in particular my mentor, Sharon Lewin, and my PhD student, my marvellous PhD student, Janine Trevelyan, who's doing a lot of the work, the clinical research team that continue to support me with the research, Kerry Watson and the HIV database team that are always there with the data that we need to look at some of these conditions. Colleagues and friends, Edwina Wright and Olga Vukovic, who we constantly talk about patients and research ideas, and Alan Cheng, who helps me with statistics. I'm about to go on sabbatical and I'm about to learn about statistics. Our collaborators at the Burnett, at the Insight Network in Sydney, the Kirby Institute, the Australian Centre for Blood Diseases and the Baker IDI. But most of all, I'd like to thank my patients, some of whom have shared that 30-year journey with me. And I've learnt so much from them, and they've always been willing to participate in the research studies, and I would like to thank them. So thank you, and thank you to my